Reporting BMIs has no
Right.
use. Doing
Uh,
suicide assessment in kids over 11 years, when it's the number one cause of death in the US for
yep.
children,
Mhm.
has an impact.
Okay,
So
I agree with you.
that's a good
I
one.
agree with you.
Social determinants for me is complicated because it just hurts me. What can I do to change this child's life?
I
But you
agree with you.
cannot look at it that way. You're trying to select people that are higher risk for
Right.
disease burden by knowing these impediments to care.
Correct.
And
Correct.
so that's what you're trying to do. So
So
that one's probably in the
all three
middle.
good ideas.
No,
Yeah, they're
BMIs.
all good ideas. The question is, what
Right.
do you then do with the
So
information?
what I found happens with all of them. All right. Let's start with the BMI since that's Herb's favorite one. The BMI, it's a darn computer. The BMI should be automatically tabulated and reported without my finger clicking anything.
And it is in some place in
Yeah,
cases with
it
the
is.
EHR we
And
use,
nobody
it was.
takes, you know what? Nobody takes the extra initiative to figure out how do I set it up in my EHR so I don't do anything. Even in our brilliant office practicum, it doesn't automatically do it unless there's this little thing that you do.
Well, but think about it, George. Think about other things that we report now. And the big one that we report is immunizations. And in New York, we also report lead to the
Right.
immunization registry.
Mhm.
Those weren't automated at the beginning, and now they are.
Right there. You have to
I give
upload
an
them.
immunization. When the immunization is entered, it's billed and it's sent to the registry. When
Mhm.
I do a lead test, it comes back from the lab automatically. It populates into the EHR and it gets sent to the registry.
That's a good
So
process. That's fast
technology has
forward physicians.
advanced
Right.
since we started. And I wrote the policy statement on immunization registries for the AAP a number of years ago. And even since then, we've seen an improvement in what can be automated and what has been automated. But man, it takes time. We see the need instantly, you
Mhm.
and I, when we're sitting there in front of the patient and we have to click to have it happen. We
Right.
know the need instantly, but in the real world, getting things changed in terms of technology requires the EHR vendor, it requires the agency you're reporting to, it requires the transmission lines, it requires them all to work together. And getting that to happen
That's
is
hard.
not as simple as you and I saying, gee, this should go automatically. It will get there. And I think we're seeing that. You've been a big proponent lately of AI scribing in the office, and that didn't come about till I retired. So I have not had a chance to see it except in a demo. And I think it has the potential for helping us a lot with our documentation. Let's remember, it's not truly intelligence, it's really just data crunching. But nevertheless, it has the potential. But that takes time. And you and I saw the need for that the first time we opened up at EHR. And
I know.
yet, how many years did it take for that to happen? Anticipating those unintended consequences might have prepared the vendors to better solve the problem more quickly. And I think that's where we fell down. We focused on EHRs as a billing tool, not as a patient management tool or a record keeping tool. But now we're getting there, and patience grasshopper, as is famously said, we will get there, but not as fast as any of us would like to see.
I remember these people that had the EHRs and the scribe companies. They're a bunch of computer geeks. They don't know what we do in the office. They give you what they think you need. And it, depending on what physicians on the other end telling them what they need, doctors in general are very complicated people. Medicine is super, super complicated. And then they put all these words out to them. And of course, these guys are going to write code to fix your super complicated problem. Even the AI scribes, for example, I've seen perfect, which are simple, easy to use, out of the box, nothing to do. And then I've seen some say, oh my God, why is this so complicated? If I have to do a demo to learn how to use the darn thing, I don't want to use it.
The only thing I push back is because Jess highlighted everything, the opportunities and the failures that we've had is it irks me that the pediatrician is responsible for the vaccination rates. If you live in certain neighborhoods in the US, either because they're Orthodox Jews or because they're fundamentalist Baptist, they don't vaccinate their kids. And if you serve that community, you can't compete with another community where everybody just says, yes, vaccinate me. And we never have a conversation about patient responsibility. What is your responsibility when you are asked to do something for your health and you decide not to do it, what is the consequence to you? Because you're making that choice. In pediatrics, the child's not making the choice, the parent is making the choice. So that might look like you're not vaccinating for pneumococcal disease. So sorry, but your premiums are going to go up by this much amount to reinsure you against a catastrophic disease.